Leukoplakia. Oral leukoplakia is a white patch or plaque that develops in the oral cavity. The condition is potentially malignant and is strongly associated with tobacco use. This is a picture of oral leukoplakia on the tongue. Oral premalignancy is considered as an intermediate stage. It is classified into two broad straplines: premalignant lesions and premalignant conditions. I repeat, premalignant lesions and premalignant conditions. The premalignant lesion is defined as a morphologically reformed tissue in which oral cancer is more likely to occur than its seemingly normal counterpart. An example is leukoplakia. A premalignant condition is characterized as a generalized state associated with a significantly increased risk of cancer. An example of oral submucous fibrosis is premalignant condition. Recently, the World Health Organization considered premalignant lesions and conditions under a single group of disorders known as potentially malignant disorders. That's a leukoplakia of the tongue. Oral leukoplakia is a potentially malignant disorder affecting the oral mucosa. It is defined as essentially an oral mucosal white lesion that cannot be considered as any other definable lesion. Oral leukoplakia is a white patch or plaque that develops in the oral cavity and is strongly associated with smoking. Risk factors include all forms of tobacco use forms, including cigars, cigarette, bidi, and pipe. Other synergetic risk factors include alcohol consumption, chronic irritation, fungal infections such as candidiasis, oral galvanism due to restorations, bacterial infections, sexually transmitted lesions like syphilis, combined micronutrient deficiency, viral infections, hormonal disturbances, and ultraviolet exposure. This is leukoplakia on the buccal mucosa. Hairy leukoplakia on the lateral border of the tongue. Etiology. The etiology of oral leukoplakia is multifactorial and many causes are idiopathic. The commonly associated risk factor is the use of tobacco in either smoked or smokeless form. Additionally, the use of areca, betel nut preparations in many parts of the world poses a significant risk, as does the use of snuff and other forms of smokeless tobacco. The role of chronic candidiasis has been linked to the development of leukoplakia, in particular non-homogeneous leukoplakia. This role is possibly related to the high nitrosation potential of some candidal forms, suggesting endogenous nitrosamine production. In some cultures, smoke from the burning end of a cigarette or similar device is retained within the mouth, and this can produce a wide range of oral mucosal lesions, including leukoplakia. Now, in these populations, such leukoplakias have a 19-fold increase in the risk of malignant transformation compared with those cultures where tobacco is used in other forms. Epidemiology. Leukoplakia is best known potentially malignant disorder of the oral cavity, and its epidemiology is well documented. The prevalence of leukoplakia varies among various scientific studies. It has a comprehensive global review point at a prevalence of 2.6% and a malignancy conversion rate ranging from 0.1 to 17%. Leukoplakia is more common in middle-aged and elderly males than other group studies, and the prevalence increases with increasing age. Pathophysiology. When a tissue cell is exposed to any type of carcinogen, it probably tries to adapt to it. An increase in cell production, shrinking the cytosolic capacity, and the allied organelle load could be an effort in adaptation. In the framework of oral epithelium, a Hazen growth phase represented by augmentation of the progenitor compartment is the earlier sequelae. When the irritant persists further, the epithelium shows features of cellular degeneration, a well-characterized feature of adaptation, and when the stage of adaptation and revocable cell damage ends, the cells gradually reach a stage of irrevocable cell damage, manifesting as either apoptosis or malignant transformation. As an adaptive response, the hastened pace of cell division noted at the earlier stages of transformation facilitates further genetic damage, thereby forcefully pushing the cells further along the path to malignant transformation. Histopathology. Histologically, oral leukoplakia present as either hyperkeratosis, mild dysplasia, moderate dysplasia, severe dysplasia, or carcinoma in situ. The dysplasia includes changes in architectural features as well as cytological features of the tissue. Architectural features of dysplasia comprise asymmetrical epithelial stratification, an increased number of mitotic figures in the epithelium, dyskeratosis, drop-shaped retipegs, and keratin pearls within these retipegs, loss of polarity of basal cells, and basal cell hyperplasia or anaplasia. While the cytological features include nuclear pleomorphism, cellular pleomorphism, increase in nuclear cytoplasmic ratio, prominent nucleoli, and hyperchromasia. The classification of mild, moderate, and severe dysplasia is applied when this architectural and cytological atypia affects less than a third, one third or two thirds, and more than two thirds of the epithelium, respectively. Carcinoma in situ is the term used when the entire epithelial thickness is involved, in which dysplasia extends from the basal layer to the overlying mucosa without invading the underlying connective tissue. I repeat, carcinoma in situ is the term used when the entire epithelial thickness is involved, in which dysplasia extends from the basal layer to the overlying mucosa without invading the underlying connective tissue. The first international conference on oral leukoplakia in Sweden described leukoplakia as a white patch or plaque that cannot be described clinically or pathologically as any other disease and is not allied with any physical or chemical causal agent excluding the use of tobacco. In 1994, during an international symposium held in Sweden, professionals established the definition as a predominantly white lesion of the oral mucosa which could not clinically or pathologically be characterized as any other specific entity. Axel in 96 defined leukoplakia as a white patch measuring 5 millimeters or more which cannot be scraped off and cannot be attributed to any other diagnostic disease. And the WHO described leukoplakia as a predominantly white lesion of the oral mucosa that cannot be characterized as any other definable lesion. There are two main types of oral leukoplakia, which are homogeneous leukoplakia and non-homogeneous leukoplakia. Homogeneous leukoplakia comprises of uniformly white plaques that are usually asymptomatic in nature. They have a lower likelihood of turning into malignancy, whereas non-homogeneous leukoplakia is irregular, flat, nodular, or exophytic in nature and resembles mixed red and white non-uniform patches. It has a greater probability of turning into malignancy. Another rare variant of leukoplakia is known as proliferative verrucous leukoplakia, is characterized more widespread and involves different parts of the oral cavity. It is more common in older women. It has the highest chance of turning into malignancy. This shows homogeneous leukoplakia on the tongue, and this shows non-homogeneous leukoplakia on the floor of the mouth. The main histopathological changes seen are keratinization of the epithelium, that is hyperorthokeratinization or hyperparakeratinization, increased thickness of the epithelium, acanthosis, basement membrane becomes thin, inflammatory component in connective tissue, changes in the cellular layer, increased nuclear cytoplasmic ratio, hyperchromatic nuclei, nuclear hyperplasia, abnormal mitotic figures, increased mitosis, pleomorphic nuclei, basilar hyperplasia, drop-shaped retipegs, loss of polarity. Treatment: eliminate all contributing factors. In the case of lesions with moderate to severe dysplasia, surgical excision or laser surgery should be the treatment of choice, especially when the lesion is on the ventral and lateral borders of the tongue, soft palate, floor of mouth, and oropharynx. Close surveillance and follow-up should be mandatory for lesions on other anatomic locations. Surgical removal is the treatment of choice for erythroleukoplakia, and proliferative verrucous leukoplakia. Differential diagnosis: candidiosis, chemical burn, leukoderma, leukoedema, lichen planus, lupus erythematosus, morsiatobecarum, psoriasis, white sponges nevi. Prognosis: anywhere from 1 to 9% of patients with leukoplakia will develop invasive cancer in the lesion or frank malignancy. Despite the excision of invasive lesions, recurrence is not uncommon. Oral leukoplakia can spontaneously regress, and hence their outcomes are difficult to follow with treatment. Overall, once dysplastic changes are seen, the outcomes are guarded. Pearls and other issues. The following factors increase the risk of malignant transformation of leukoplakia: female gender, a long duration of leukoplakia, leukoplakia in non-smokers, that is, idiopathic leukoplakia, location on the tongue and floor of the mouth, size greater than 200 millimeters, non-homogeneous type, presence of Candida albicans, and presence of epithelial dysplasia. This is a comprehensive review of oral leukoplakia.